Thank you for the invitation. What I'm trying to do here is I'm not going to try to teach you anything, as my compatriot said. I just try to make you think. These are my disclosures. I think this is a mandatory slide for most of us. Just trying to highlight the fact that the aorta is an organ, it's not a tube, and we should treat it like that at all times. So we're going to talk about the arch. Some facts about the brain before we started, so we can bring everyone into this up to speed, because some of the people in here may not necessarily be aortic surgeons. For every drop in temperature, body temperature, we have an overall cerebral metabolic reduction in the oxygen consumption by 6 to 7%. We do not have a true consensus on what is the ideal temperature for neuroprotection. And then if we need to actually talk about how do we protect the brain, we need to talk about metabolites and metabolomics. When we drop the temperature, most of the metabolites drop. However, glutamic acid uptake is increased in hypothermia. So do we need to increase our glutamic acid in the blood or decrease it? Is it good or is it bad? We don't know. So there are a lot of unanswered questions there. What do we already know? And how do we search for information? I suppose a lot of us, we go to the PubMed, we fire some words, and we see what comes out. So this is what I've done. With regards to normothermic arch, about 30 publications, and a third of them were published in the last 10 years. However, is that the only way of looking for evidence in the modern era? Does anybody else use anything else? Thank you. So, yes, this is the old way. We have to interpret the data. We have to go and search for it. But in the modern era, we have GPT engines. And we need to understand that we should use them. Okay? It's a linguistic tool. It just summarizes the evidence. But for many people, maybe a good way of also searching for evidence. So what do we already know? We know that normothermia aims to reduce the risk of neurological complications. So if we do an operation in normothermia, the body suffers less. However, individual patient outcomes still vary. Normothermia provides an optimal condition for organ perfusion, whatever organ that is, including the aorta. The aorta is an organ. Success depends on patient selection. You have to understand your patient. You have to explore the options on the patient. And preoperative assessment is crucial, as per every other complex procedure that is performed. Surgeon experience and expertise play a significant role. Normothermia requires expertise not only from surgeons. For complex aortic surgery, it requires expertise on the perfusion and anesthesia. So you need to work in a team, not in isolation. Of course, ongoing research and advancements contribute to improving success rates. But what we are here today, we're here to collaborate. We're here to exchange ideas. We're here to talk to each other, work together, so we can achieve better outcomes. What we don't know, that adverse outcomes due to inappropriate temperature management are likely underreported. We are very good in reporting success and how well we do. We fail to report when things do not go well. So let's go into technical aspects. When we're talking about the arch, we're talking about debranching to start with. This is something that most of the advanced aortic units do. We do some in Oxford as well. There are intrathoracic debranching when you do a thoracotomy and you debranch the head and neck vessels and you stand across the arch. Or extrathoracic debranching where you do not open the chest. You just debranching on the head and neck vessels and then you stand across the arch. However, that's not aortic arch replacement. So aortic arch replacement is when you chop off the arch and you throw it in the bin and you replace it with something else. So we're going to concentrate on this one now. When we're talking about aortic arch, a thing for me is, the more I do, the more I realize that zone 2 is an important zone. Quite often I find that I have patients that have a lot of aneurysms before the zone 2, or some of them they have after the zone 2. When the zone 2 is aneurysmal, usually the whole arch suffers. Usually the descending thoracic aorta suffers. But the most stable part of the aortic arch is actually the zone 2, I think. I haven't got any clear and strong evidence to prove that, though. So for me, there is a line. I draw the line of the zone 2. If you do a normothermic arch after the zone 2, it's a complicated exercise. It's been done, not at Oxford. It requires maybe 2 pumps, very endo balloons, very complex exercise. I cannot fit all those things in my operating room in Oxford, I'm afraid. So I've got no experience on that, but it's been done. What I'm going to talk about procedures that are performed from zone 2 and proximally. This is what we do at Oxford in normothermia. So over the past 18 months, we've done 8 cases. We had 0 mortality. We've done a variety of complex procedures. And the average hospital stay is about 10 days, varying from 6 to 17. 3 of those cases were redo cases. And our cardiopulmonary bypass time is about 130 minutes and cross-clamp time about 90 minutes. Re-exploration for bleeding, 0. Blood loss, very acceptable. Complications post-operatively, very acceptable. And strokes, we had 1 patient with stroke. However, that patient came to us with a big clot inside the brachioencephalic artery. And we had to take it to theater with a stroke to start with. I think that one of the first fundamental steps before you embark into that is to understand the disease. And you should discuss that with your colleagues at the MDT. You understand the anatomy, you understand what you want to do, you have to make a plan and plan ahead. And when the patient comes to theater, at Oxford, we have a good discussion. Everybody comes over, we have an explanation of what we're going to do, on how we're going to do it, and we like to draw. We do a lot of drawing. So everybody in the room understands exactly what we're going to do. And the important thing there is to make it simple and explain the what if. What if the pressures go up? What if things do not work? What are we going to do? So the perfusionist is happy. The anesthetist is happy. Even the last circulating nurse in the room is happy. And they're content. They know what's going to happen. The first fundamental thing for doing a normothermic arch, I think, is the subclavian cannulation. Without this, you can't do it, in my books. And you have to identify it and then put a graft on it. Now, when we do this without full heparinization. We just give 5,000 units of heparin, enough for us to clamp. And then we do the anastomosis, and then we connect to the pump. And when we finish with DIA, we connect with flush the graft immediately. So do not allow any blood inside the graft to allow for any clots to form or anything like that. Then we pack it up, don't pack it too tight, and we set up our subclavian cannulae in such a way that we make sure that they are not twisted. The graft is not twisted. So we pay attention where the black line is, we line it up, and then we cover the graft. And covering it, it gives you two things. One is keeps the graft clean. If you need to use the graft later on to do any extra anatomical bypasses or anything, it keeps it clean. It keeps it out of continuous exposure to air, blood, products, everything. And also, it controls a little bit the bleeding. But it's very important to make sure that the graft, when you put it underneath the swabs and you cover it up, is not twisted. So you have to pay attention to where the black line is, and then everything is relatively simple. So ultimately, when we're doing both sides, the patient looks a little bit like that. At that point, there are only 5,000 units of heparin. So no heparinized, so you can open up the redo case with no bleeding. But your perfusionist should continue flush those lines all the way through, every couple of minutes. So no blood coming back, no clot formation. Now, some pitfalls, because not everybody is doing that as a regular thing, maybe. When you open up the subclavian, when you put the side-body clamp on it, be aware that the back wall is going to come to you. So don't go deep with your knife. You're going to cut the back wall. When you use a graft, bevel it. Bevel it by at least 3 rings. And that is because you're going to get better flow dynamics. If you actually stick your graft 90 degrees, then instead of having a flat line on the perfusion, you're going to start getting oscillations because your flow hits the back wall of the innominate of the subclavian artery, and you may dissect it. When you stitch the graft inside the subclavian artery. Remember, the flow will come down the graft. So you don't want the artery to be inside the graft. You want the graft to be inside the artery. So you minimize the risk of dissection. And you keep the black line at 12 o'clock, so you know what it is. It doesn't get twisted. We use 3/8 connectors for 10 millimeter grafts, and we use 22 EOPAs for 8 millimeter grafts. And we keep flashing every few minutes because we are not heparinized. During these procedures, you need to set up the patient right. So the patient should have 3 arterial lines, should have EEG monitoring, it should have continuous saturation monitoring of the brain. You need to understand what's happening. You need to be happy that this one is actually performed to the best benefit of the patient. Now, next one is where you're going to put the clamps. There are different ways where you're going to put the clamps, and that depends on the arch anatomy. Not every arch is the same. The arteries are not in the same distance on each patient. So you can put it in various ways. We have some more beveled clamps that we use. And of course, you clamp the proximal thing, and you can carry on giving plegia or even put, use warm blood and let the heart beat at the other end, where you do the arch. And then when you put those, before you put the clamps on it, you have to completely mobilize the arch, the whole arch, including 1 or 2 centimeters of the head and neck vessels. You need to get the arch in your hand, basically. Identify and preserve the recurrent laryngeal nerve. In order to do that, don't go at the front. It's difficult to find it sometimes. Go at the back of the arch. It's easier to see it there. Trace it from there to the front. And you almost, even in the redo case, you should be able to find it, push it away, and you do not traumatize it. Make sure that the quality of the tissues are good enough for clamping and to sustain sutures, because if they're not, forget it. You need to cool down and keep the patient safe. Apply the cross clamps and flow down, and then stop. After that, what you need to do is talk to your perfusionist and talk to the anesthetist. The pressure should be good, the pressure should be equal, pressure should not go up, the perfusions should be equal, because if they're not, if there are any issues, then that's the time that you should cool down. If all positive, that's great. You're just a couple of hours away from going home. Otherwise, you spend another few hours cooling down and rewarming. And if you've done all that, that's it. It's 4-0 Prolene from then onwards. Anybody can stitch the two ends. It's all about setup. Now, in our experience at Oxford, we have a very low threshold to actually repair the right atrioventricular valve, or tricuspid as it's known, especially if we do a root aneurysms. And that is because I think what happens is that you have some movement in that area in between the aortic root and the tricuspid valve. And the minute that you release, you take that big aneurysm away, your tricuspid valve annulus actually gets even bigger to what it was before. And what we found is that if you go in electively and repair it and accept it, when you're rewarming, it's easy. The patient comes out with less anatropes, with no TR. Things are a lot better. End result, we usually assess it at about 3 months, really, when all the blood is gone. This is a case that we did in February, and that's the last case that I've shown you the videos and everything. So I'm afraid the CT scan, the follow-up is not at 3 months, it's immediately post-op. And the end result is, as you can see, the arch has been replaced, the ascending aorta has been replaced. This is a redo case, and is being done in normothermia. So normothermic arch surgery is a procedure that can be done safely at specialist aortic centers. But of course, we need more validation of the techniques as we go along, and we can work together to make it better. Thank you.